60 to 80% of infections are biofilm related.
Hmm.
So I would say if you've got a biofilm producer in your sample, it likely came from a biofilm.
Hi, welcome back to the Live UTI Free channel. My name is Melissa, and today I'll be interviewing Dr. Nicholas Sanford, the Vice President of Medical Affairs and the Assistant Lab Director at MicroGenDX. We've collected many questions from our audience for this interview, and in part one, we'll cover the differences between standard UTI testing, PCR, and next generation sequencing tests. We'll also discuss how and when to collect a urine sample. We have a lot of information about UTI testing on our website, so we'll share some links in the video description. If you enjoy these videos, think they're important, and want to support what we do, remember to hit subscribe and tick the bell so you get notified every time we post something new. Thanks again for joining us on this journey to making change in women's health. Speaking with Dr. Nicholas Sanford, the Vice President of Medical Affairs and Assistant Lab Director at MicroGenDX. We've had many requests from our community over the years to interview a scientist from MicroGenDX, so I'm very glad we've been able to organize this. Thank you for joining me to share your expertise.
Thank you for having me. I'm very excited about this interview.
I'd love to hear more about your background and how you became interested in this area of research.
Well, it's kind of a funny story. I went to Texas Tech and I got a bachelor's degree in plant biotechnology. And then I went directly into a PhD program studying the molecular biology of cotton fiber cell walls. After I graduated, I guess a big part of my graduate project was, sequencing ancestral cotton genomes and a lot of PCR work. So after I graduated, I was looking for places that I could use those skills. And I stumbled across this little company called Pathogenius that's located here in Lubbock, Texas. And it was owned by a wound care physician named Dr. Randy Walcott. And he was very innovative in that he established a physician office lab where he was using molecular diagnostics, qPCR, and next-gen sequencing in order to diagnose and better treat these chronic wounds that he was seeing. So I started working for the company as a bench technician. And over the years, I began designing a lot of the assays that we have, a lot of the PCR assays that we have on our menu. In 2020, I designed our COVID assay. And I spent a lot of time on the phone with physicians and patients explaining, how the assay works, the benefits and limitations of the assay. And that kind of transitioned me into this medical affairs role that I'm in now.
And can you give us some context for the types of tests that MicroGenDX currently offers?
Absolutely. Well, the data from this qPCR plus NGS approach was so promising in wound care that it rapidly expanded to just about every other area of infectious disease. So we're doing testing on samples that can be collected from almost any body site for the purposes of diagnosing infections. So we've done a lot of work over the years to validate, all of these different sample types that we can accept in order to make this test accessible to the patients who need it.
At this point in time, can you estimate roughly how many UTI tests you've processed?
Ooh, that I don't know. I do know that urological samples are our highest volume test, and we've done, well over 1 million assays.
That's a lot. And it's probably one of the reasons we receive so many questions about MicroGenDX testing, how it's different to other types of UTI testing available. But I think it makes sense to first start with some of those other types so that we can talk about the differences in sensitivity. So the first question is, why are dipsticks so unreliable?
Well, the dipsticks, I don't want to bash the dipsticks too hard. The combined performance of leukocyte esterase and nitrites is a pretty good indicator for an accurate dipstick diagnosis, but those markers have limitations. In your urine, you have chemicals called nitrates, and there are some bacteria that will convert these to nitrite, and that's what's measured with the nitrite test. The problem with it is some organisms don't produce nitrite, so those would be missed in those scenarios. The other marker is leukocyte esterase, which is an indicator of the presence of white blood cells. And this, most commonly, the white blood cells in the urine are going to be the result of an infection of some sort, but there are other things that can cause it. Prolonged use of aspirin, corticosteroids, and diuretics could lead to elevated white blood cell count in the urine. But I think most importantly, neither one of those markers identifies an organism and helps you treat.
Right. Yeah. I guess that takes us on to standard culture then. And why might that test be negative despite someone's symptoms of UTI?
Well, standard culture is predicated on having viable organisms to grow. And this is sounds easy, but it's not. There's a lot of transport requirements after sample collection to get the sample to the lab in a certain amount of time, and then you have to set it up. And when you're setting it up, you have to guess at what kind of media you want to grow it on. Do you want to look for aerobes? Do you want to look for anaerobes? How about fungi? Are you interested in acid-fast bacilli? These are all different cultures that you have to run. And even if you're running all of these things, we can still only identify about 2% of the bacteria we know of with these methods. So because of that cultivation bias, we also know that standard urine culture is poor recovery of biofilms. And just because some things just grow better in culture than others. And we also know that within the biofilm, some things are metabolically less active than others, and those might take a while to resuscitate and be outcompeted in the culture. So I think there are these issues with it. A previous antibiotic exposure is another big reason why you might see a negative culture, when you're definitely have an infection going on.
Right. So then the next step up from there is PCR testing. Can you explain what that is?
So PCR asks a very specific question, and you can do a whole bunch of PCRs at one time to ask a bunch of specific questions. And these questions might be, is Staphylococcus aureus present in this sample? You could also ask, is MEC-A present in this sample? And now you have a PCR that can detect MRSA. But it can't tell you about anything else that might be in that sample because you haven't asked those questions. So what PCR is doing is it's amplifying specific pieces of DNA, which are like fingerprints. Basically, they're specific to an organism. And the way they're doing this is we have DNA that's been extracted from the sample that comes into the lab, and we combine that with short pieces of DNA called primers, and these bind to the genomic DNA in the sample, to the target region. And then we have a DNA polymerase, which is an enzyme that will stitch together the DNA in between the two primers and give you a PCR product. This method is incredibly sensitive with a theoretical limit of detection of a single copy per mil, which is fantastic, but it's got its limitations as well. Like I mentioned, if you don't have primers for a certain organism, you're going to know nothing about it. So we call this panel bias. And there's some studies that show the real world effect of panel bias. There's an interesting one that was done by the Mayo Clinic where they compared their targeted NGS to the BioFire joint infection panel, which is a PCR test. And what they showed was that in real world samples, that PCR test had a sensitivity of about 56% because it didn't have things included on the panel that cause, in that case, periprosthetic joint infections.
Right.
So I think another limitation could be mutations in the targeted sequences. So if you've got mutations there, your primers aren't going to match up and bind anymore. So that's another limitation of this. I would say that PCR is significantly more rapid and sensitive than a standard culture, but it can't detect as many organisms.
Can it detect organisms that were inside a biofilm?
It can. So the detection of biofilm, molecular methods are really good at it because they're not trying to grow anything. We're just breaking that sample open and looking at all the DNA that's there. So as long as you've sampled the biofilm, it can be detected with PCR or NGS.
I suppose that's an issue for any test. If it's not in the sample, you're not going to detect it. So
Correct.
after PCR is next generation sequencing, or NGS, which is another type of technology that MicroGenDX uses. Can you explain the difference between PCR and NGS?
So if you're asking questions, you're asking very simple questions with PCR. NGS is asking a much broader question. Instead of, is Staph aureus here? NGS asks, what bacteria are here? And it also asks, what is the relative abundance of each? So you can figure out who's dominating the mix Maybe you've got a nice evenly dispersed mix that's, you've got some high variability. It looks reflective of your normal microbiome. So it can ask those broader questions. And the way that it's answering those questions is by comparing sequenced DNA to a large reference sequence database. There are a few different types of NGS. So there's targeted NGS, and then there's metagenomic NGS, which is whole genome sequencing. What we're doing is targeted NGS, and we're targeting the 16S and 18S regions of bacteria and fungi in order to identify them. So 16S and 18S are part of the ribosomal RNA genes, and they're very important to cell survival. So they have regions in them that are called hyperconserved, meaning they don't change over time. They don't have a tendency to mutate because that would make problems for the cell. But in between some of these hyperconserved regions are what we call hypervariable regions. And in here, the DNA is so different from species to species that you can actually use it as a fingerprint and identify them by that region. So that's kind of what we're doing. But NGS, has its limitations as well. For targeted NGS, we're not going to have full genome coverage, so we don't get any information about resistance genes. We don't get strain level identification. But it is significantly more sensitive than PCR and culture. And our particular test is capable of detecting over 50,000 unique bacterial and fungal species.
Right. And we talked about whether these tests can pick up biofilms. What about for infections that are embedded within the bladder wall? Could NGS detect an infection like that?
Absolutely, again, it could, but then this again is predicated on sampling the biofilm. So as long as it's contained, it's in the sample, then it'll be able to detect it.
So if cells from the bladder wall that contain bacteria are shed into the urine, then the test will be able to detect them.
Absolutely.
Great, that's good to know. And why do you use both PCR and NGS at MicroGenDX?
So well, we like the PCR because it provides a rapid result for some of the most common things that you see. It also gives us access to the antimicrobial resistance genes. I mentioned we're doing the targeted NGS, which can't see the resistance genes. So the PCR helps complement that.
Right.
PCR is also helpful because there are some instances with targeted NGS where you're using 16S where certain species can't be differentiated. So we will also use the PCR panel there to break ties.
Okay, and so why on your tests do organisms sometimes show up on PCR but not NGS and vice versa?
Well, sometimes if the organism is found and it is something that's included on our PCR panel, but the PCR seems to have missed it, what's likely happening there is a mutation in the primer binding site. And this is another reason why we like to complement qPCR with NGS, because while qPCR might miss that because of the mutation, the NGS is looking at a different part of the genome, and where it's looking, it can pick it up. Also, it's less prone to those mutation errors because it's sequencing a large portion rather than, do these 3 target binding sites match.
When you're using PCR and the type of NGS that you utilize, what's the chances that you'll miss the organisms completely?
Well, every test has a limit of detection. So if it's below the limit of detection, we'll miss it. Other than that, I think the sensitivity of the PCR is incredibly sensitive with that limit of detection. But also the discovery power of the NGS. I think if there's something in that sample, this test is most likely going to pick it up. There, of course, are situations where maybe there's some kind of inhibitor in the sample that's going to prevent amplification. Or, if there was something maybe happened in shipping and the DNA was degraded en route to the lab. Things like that happen occasionally.
Okay, and we've got a couple of questions about specific organisms. You mentioned that your NGS database is about 50,000 organisms. Does that include the organism that causes Lyme disease?
While it's in the database, the regions that we're sequencing are not optimal for
Hmm.
Borrelia or other tick-borne stuff. So we don't really advertise that we're able to pick up Lyme disease or those infections. That is something that gets brought up to us a lot.
Hmm.
So we're always looking at ways to do it. But the biggest issue doesn't seem to be coming up with a PCR or sequencing it. It's
Hmm.
how to collect a sample
Yeah.
that's going to actually have the organism in it.
Yeah, I was wondering about that too, because from what I've read, that's often within the bladder wall and not always in a urine sample, which is another layer of complexity.
Mhm.
And people also ask to what extent the test can detect yeasts.
Well, in our database, we've got over 34,000 fungal species, but I don't have the breakdown of yeast and mold.
Okay, that's a lot though.
It is.
And then when it comes to detecting organisms that have been in a biofilm, is there a way to confirm that there is a biofilm in the bladder? And is that even helpful given that a healthy bladder also contains biofilms?
It's possible to demonstrate the presence of a biofilm, but those methods probably are still too cumbersome for routine clinical lab use.
Hmm.
I would say that in nature, biofilm is the preferred mode of growth of bacteria
Hmm.
because of the protections that it affords. The NIH has even published a study claiming that 60 to 80% of infections are biofilm related.
Hmm.
So I would say if you've got a biofilm producer in your sample, it likely came from a biofilm.
Right. Makes sense. And do you plan to provide STI testing that is using NGS or sticking with the PCR?
Well, we're always looking for ways to improve. Our targeted NGS is only targeting the bacterial and fungal species, so the PCR can help us with parasites and viruses like
Hmm.
Trichomonas or HSV. It also gives us the antimicrobial resistance genes. But we have invested, we're sequencing labs, so we've invested in, all of the new technology. We've got the long read and the short read sequencers. So I think it's certainly possible that a metagenomic offering to provide very detailed information on STIs could be on our menu and in some
Hmm.
fashion in the future.
I'm sure a lot of people will be interested to hear that. Now that we've talked about these types of tests, why is it that they're not generally covered in guidelines for clinical practice?
Well, to get into the guidelines, you've got to have, an overwhelming amount of clinical evidence. And I think the IDSA signaled that we've hit that point recently with their update to their guideline,
Hmm.
which is now recommending NGS for a large swath of different infection types. Unfortunately, urology was left out.
Mm.
The editors of that section simply referred readers to the AUA guidelines. So Um, what we've got going on there is there is a petition on change.org
Hmm.
written by a Miss Carrie Ann to make advanced testing like this part of the AUA guidelines. And that petition is doing very well. It's got over 31,000 signatures with a goal of 35,000.
Right?
Um, so if people could reach out and sign that petition, that would certainly help move this technology into the guidelines.
Yeah, I can drop the link in the video description for anyone who's interested. Well, we've spoken a bit about whether an organism is in a sample. So I think it's a good time to start talking about how to collect a good sample for a MicroGenDX test. Can you first describe what a MicroGenDX test includes?
Sure. So if you're ordering the UTI kit, it's going to come with a 90 ml cup and a bio bag. The vaginal kits are going to come with 2 dry flocked swabs in the bio bag, and the prostate kits come with a 90 ml cup and one flocked swab with the bio bag. Um, Occasionally, if you feel like maybe you've had an error in collecting your samples, reach out to us before sending it in, and we can replace those collection supplies for you.
A couple of people did ask about that, whether you send backups in case an error happens during collection, or sometimes people will collect a sample and then their symptoms will get worse and
Mhm.
they'll want to recollect because it seems like a better time. So it's good to know they can reach out for a replacement if needed. And what's the benefit of the combined urine and vaginal swab test?
Well, I guess it's going to give you more information. We see a lot of people running these paired samples together, and it's not uncommon to see different organisms in the different body sites. So I think this, it's certainly helpful in just giving you more information, but it might also be helpful in cases where you've got inconsistent or unlocalized symptoms and you're not sure where the sample might be best taken.
Is that then the case with prostate test alongside a urine test as well?
I would say so.
Okay. Do you think for a female who experiences recurrent or chronic UTI that it makes sense for a male partner to also get tested?
Absolutely. Yeah. I mean, I think it's certainly feasible that we serve as reservoirs to one another. I mean, we spread infections to each other all the time. So
Hmm.
spreading infections like this, it makes perfect sense to me.
Are you seeing more clinicians take that approach? Because we have had a lot of pushback on that suggestion over the years.
I mean, it's hard to say. I don't see what's coming through on the day to day, and oftentimes we don't know if people are related or
Sure.
not. We're just getting, we get a sample and a little bit of information about the patient. So
Yeah, that makes sense. We do have an interview on our channel with Dr. Tim Levinka who talks a lot about this topic and partners who may be transferring organisms and when to test. So people can refer to that too for more information. Is it best to collect a sample when symptoms are present? And for people who have continuous symptoms, should they wait until their symptoms are worse than they are usually to collect their sample?
I would say it's just generally recommended to collect samples when your symptoms are present, and I would say first thing in the morning because
Hmm.
those samples are going to be more concentrated. If you're having continuous or chronic symptoms, I wouldn't wait for things to get worse. I would
Hmm.
just collect samples when you're experiencing representative symptoms.
Okay, and so you mentioned collecting in the morning if possible. Do you require a midstream sample or is there something else that you recommend?
Midstream is most common, and it works well when the collection instructions are strictly followed.
Mhm.
So like if you think you contaminated the sample, you probably did. It's time to reach out for and get new supplies.
That's a good approach, I think. And if someone has taken antibiotics, how long should they wait before collecting a sample?
We recommend waiting about 48 hours after you
Hmm.
finish to collect a new sample. If for any reason you can't do that, we can still process the sample while you're on antibiotics.
Is that the same advice for someone who's been on antibiotics for a long time, say 6 months to a year? Or would you recommend that they wait for longer?
Our current recommendation is 48 hours simply because we haven't done that kind of study to
Hmm.
determine if there is a longer window period that it needs to be. But I think we certainly don't see a certain population who is having a higher negative rate because of that.
Okay. And for people who are on long-term antibiotics and have breakthrough symptoms, can they collect a sample at that point, and how will the antibiotics affect that?
They can collect a sample. The antibiotics shouldn't affect it too terribly. There are two studies out there that I'm aware of. One was done in our lab and one wasn't, that show the effect of previous antibiotic exposure on test positivity. And
Hmm.
we've seen, we run some biomarkers for our ortho tests, and all of those are impacted by antibiotics, but the NGS is not.
Okay.
Um, the other study looked at a wide variety of sample types, and they looked at previous antibiotic exposures, and they saw the same thing, that cultures were significantly impacted, but NGS test positivity remained strong.
Okay, interesting. And do you make the same recommendations about the 48 hours for urinary antiseptics like Hiprex or methenamine?
Yes.
Okay, that's good to know because a lot of people are on methenamine now, and it's a question that we get quite frequently. Some clinicians recommend taking a biofilm disruptor prior to testing. Have you seen any benefit to this or any change in the results?
This isn't something that we've studied in detail at our laboratory, but the research available seems to suggest that they certainly enhance the detection of biofilm-related organisms.
Do you think there's any benefit in testing when UTI symptoms are not present for someone who experiences recurrence?
Absolutely. I think testing your microbiome during these symptom-free periods can provide an idea of the normal state of things. It can
Hmm.
also show what kind of shifts might happen because of changes in your diet or medications you're taking, and I'm sure many other things. I would like to point out that our test is not a microbiome test. It is a clinical diagnostic intended for detecting infection.
Hmm.
So so that's why, like, we often get questions like, I did a microbiome test and I did a microgen. Why don't your results match up? And it's because we're doing different things.
Hmm. Fair enough. And you have a lot of international patients. How does the transit time of a sample impact the results?
So most of the sample types that we accept are viable for 21 days at room temperature. They don't need to be refrigerated or frozen prior to shipping. But if for any reason you collect a sample and you store it in the refrigerator or freezer, we do recommend shipping it on ice, because when you go through repeated freeze thaw cycles, that can degrade the DNA in the sample.
Okay.
I will also say that because we're talking UTIs, if you're going to send a urine sample and you've ordered the biomarker UA portion add-on to that test, then we need to receive it within 72 hours, because time in shipping will impact biomarker results.
Right. If for someone who is not doing the UA part of the test and collects on a Friday, is it best to just leave it at room temperature and ship it on a Monday?
Yes.
Okay. That's good to know. I think the assumption would usually be that it's better to put it in the fridge, but it sounds like that is not the case.
I mean, like, it's something that we get asked about a lot. So we've done these studies and we've done them at, zero, like at freezing, we've done them at 100 degrees.
Hmm.
And it seems like we don't see any changes in the bacterial load or the relative abundances up until after 21 days.
Okay, that's quite a long time. Surprising.
It is.
Thanks so much for watching. I hope part one of this interview helped to add to your knowledge about UTI testing. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveutifree.com for more info. We'll also add some links in the video description. If you like what we're doing on this channel, be sure to hit subscribe and tick the bell so you get notified of our future content. Thanks so much for watching, and until next time, keep asking questions and pushing for better solutions.